Welcome, class. In today's video, we will be going over some basic head and neck pathology, primarily focusing on the head component. We will mostly be looking at the oral cavity and the pathologies and specimens it will generate. When we are looking at pathologies in the head, it's important to go back to your anatomy as far as skulls go and being familiar with the bones. We will also be taking a look at the maxilla as well, but we won't be focusing on that heavily. Most specimens will be the mandible, and if you apply the principles of mandibulectomy specimens there, you should be able to handle maxillas, although they're slightly more complex. So the first thing you should see in a characteristic skull like this is our mandible, which is our bottom component. This is completely separate from the skull and can actually be removed, which we'll go over in more detail here. But our maxilla bone is this paired bones segments right here in the front. Up top we have our nasal bones, you have your zygomatic bones. And those can all be involved in a specimen for a maxillectomy. So multiple bones involved can also add to the complexity of it. Additionally, you can see in the image provided the different types of maxillectomies that will be seen whenever you receive these specimens. So we'll mostly be focusing on the mandible because that's an easy to resect component, and mostly we see partial mandibles in surgical pathology labs. So when looking at the mandible, again, this is something that can be received exclusively without a skull, and you might get portions of these. A lot of times they'll section something along the midline, like the specimens you'll received, or maybe cut something along the lateral aspect. But the key thing is you'll have an anterior and a posterior, or more likely a proximal and a distal bone margin that you're going to have to worry about. So in the mandible, it's got this nice characteristic shape to it, this U shape, and what you'll notice, we have the mental foramen, which the mental artery nerve will come out of. You also have the portion where the teeth reside, and in the oral cavity, this is referred to as the lower alveolar ridge, where our teeth are, and we'll actually see mucosa, specifically the gingiva, lining right on top of here. Up here would be where our lip mucosa is. We don't have any on here, obviously. As far as the mandible components, we have the body, which is kind of the anterior part, that U-shaped part. The flat portion is the ramus, and the angle where the ramus and the body meet up. You have two prominences on the back. You have a condylar process and a coronoid process. Now, the condylar process is what actually makes our TMJ joint lock into that joint region in the skull, which we have here. So you can see, and that adds a pivot point for the skull to open and close via, whereas our coronoid process is a little more free attached and will actually remove from the skull depending on mastication. So most of the specimens you'll get will actually be received cut anterior to the ramus, but you might see a wide variety of these specimens. But it's nice when we look at these because realistically you're just going to have two bone components from a single bone, so two bone margins, I should say. Additionally, if we were to look on the inside, we have our mandibular foramen, which may not be attached, but we know that our inferior alveolar nerve and artery go in there and ultimately will exit out through the mental foramens on either side. And then you have your mandibular notch, kind of a key characteristic. Again, you won't really see that in your surgical specimens. Another thing you probably won't see are these nice little springs here, which you can imagine might attribute to our TMJ lockjaw syndrome. You know, if you don't oil those suckers up real well, they might just get real stiff, prevent you from opening that jaw properly. But no, we don't have, for most people, we don't have springs in our jaws. This was just from a skeletal specimen. So when we add mucosa to this, I'll put an overlay for that. It's important to know that the various sites where our potential cancers can be located in a mandible specimen. So if we were to have a lip attached, you'll see that a common site for cancers tend to be in this area between the gingiva and the lip, as well as the buccal mucosa, which makes up the inner lining of the cheek. You'll see cancers forming on the lower alveolar ridge, whether anterior or posterior to the teeth, and you might actually see them in the retromolar gingiva, which is right around the molars in the back here, as well as the base of tongues. So some of these specimens may actually come with partial glossectomies. If that's the case, you could have a tongue component comprised of it. as some of the soft tissue margin. But some of the base of the tongue right underneath the tongue tend to be a common site for cancers as well. The most common tumors you'll see in these mandible specimens and these face specimens is squamous cell carcinoma. There is actually a strong link between HPV 16 and 18 for head and neck cancers, as well as smoking, tobacco use, all tend to be associated with cancers. These specimens, whether they're mandible or maxilla, are often called composite specimens, primarily because they're just multiple factorial as far as what they include. So you'll have bone, soft tissue, mucosa, and maybe some nerve and vessels that you might have to be aware of as well. So common overall term is composite. But the proper term for this specimen would be a mandibulectomy, and if it was a maxilla, it'd be a maxillectomy. Okay, now let's take a look at an actual specimen. This is a partial mandibulectomy specimen. That's something you were able to help me create in the cadaver lab. So now we can actually see how the specimen will look in a real-life patient. This one actually does come with the attached tongue, so we got a partial glossectomy as well. So this may or may not be the case. You're welcome to work with it having the tongue attached or not. And we'll see kind of the best way to approach that. But ultimately, I want you to get the concepts down of margin assessment. So the most important thing with these specimens is margins and worrying about them. Of course, that's the same for every specimen, but these ones will have you thinking a little more three-dimensionally. So before we really dive into a specimen like this, we should really do a nice overview of what margins are and how it relates to soft tissue and mucosa. And unfortunately, I have just the person to go over this. Allow me to introduce Dr. Margin.
Hello, I am Dr. Margin. I am told you are interested in learning about the ins and outs of margins, particularly for these composite resections. Well, you're in luck because I am hopefully going to teach you a thing or two using my handy-dandy margin assessment tools. Now, the basic definition of a margin is that it is a place where a surgeon made a cut inside a patient. And so it's important to assess whether or not there is malignancy or any sort of disease process at that cut, because the likely indication is that there is still disease process inside the patient. So, margins can be looked at in several different ways depending on the structure that we are looking at. Let's start with the most simplest margin to understand, a tube-like structure. Now, with the specimens you will be looking at, this could be attributed to what a bone margin will look like, particularly in the mandible. Now, I'm going to go ahead and cut this and show you that the cut surfaces I see, whoops, got away from us there. I've cut this so that we have 1, 2 margins on either end, keeping in mind that the other pieces that I did cut would still be technically in the patient. So, in a mandibular resection, we have 2 margins, particularly usually an anterior and a posterior margin, for which we're worried about. The next simplest margin to look at is the two-dimensional mucosa margin. So let this paper represent our mucosa. Now, notice it's a flat surface and we take two-dimensional measurements of this. Now, if I were to come in and make cuts, wherever I'm making a cut is now my margin. And so, if we were looking at a mucosa specimen after the resection has been made, there are exactly 4 margins. Now we can piece this together with our previous margin and lay it over the top. And we can say that maybe our anterior margin lines up with our anterior mucosa margin and our posterior bone or tube margin lines up with the posterior mucosa margin. So that's pretty straightforward. 1, 2, 3, 4 margins on mucosa. 1, 2 on our tube structures or bone structures. So now let's get into a little bit more detail with the three-dimensional margin. In front of you is a piece of cotton. Now, this isn't exactly a rectangular shape, but we'll make do. Imagine this as 6 complete straight sides. You may get specimens that are a little amorphous like this, so you're just going to have to arbitrarily assign which ones are margins. But if we were just to get a specimen like this, which you might see in a lumpectomy, or perhaps a soft tissue specimen, we would have 1, 2, 3, 4, 5, 6 margins. That's your anterior, posterior, medial, lateral, and superior and inferior margin. Now, things get even more interesting when we start combining the various components, and Wester has a really great image on how to properly assess these. Taking our 6 margins for the soft tissue component, let's go ahead and overlay our previously cut mucosa. Now would you look at that? If you're keeping track, the mucosa is covered completely on the superior side in this specimen, and that means there's only 5 remaining for the soft tissue margin. Should this evaluate a little bit differently, you might get some variation in your margins, but if you know your anatomy, it shouldn't be an issue. For purposes of simplicity, let's just look at this. Now, that means our specimen that originally had 6 margins is down to 5, and our mucosa still has the 4 margins we previously assessed. The only difference is the deep margin, which we will argue is our inferior margin in this case, is not part of the mucosal margin. It is soft tissue margin. Now, let's really throw things for a loop and add our bone. We're going to go ahead and slide that into our soft tissue, just like that. And let's go ahead and put our mucosa on top. And just like that, you can see how 3 different components come together to make multiple margins. So we have the 2 from the bone, 1, 2. We have the 5 from the soft tissue, 1, 2, 3, 4, 5. And we have 4 from the mucosa, 1, 2, 3, 4. Now, depending on your specimen, your margins might look slightly different. But as long as you understand the basics of the margins and are able to articulate each individual prospect, you can assign margins for your specimens as needed. Now, let's return to Matt in his previously started prosection video. So now it comes time to ink the specimen. Now, we are dealing with 5 different margins, so we want ideally 5 different colors. Now, if you did happen to have a 6th margin exposed, ideally like the superior margin due to maybe some buccal mucosa / buccal soft tissue being included, then you would use 6 inks. But for this lab and demonstration purposes, we're only going to use 5 colors. Those 5 colors are completely up to you, but one thing I recommend when you're doing grossing is to try to keep your color patterns consistent. Some people come up with mnemonics like blue is sky, so use that for superior, green is grass for inferior. Some people like to use black as always posterior / deep. At the end of the day, try to be as consistent with your inking colors as possible, because ultimately if there is a mishap or a mislabeling of your cassettes and you always keep the same habits, then you'll know that a particular color should always be a particular margin. So keep in mind those kind of practices when you're grossing. Now, I'm going to go ahead and ink this specimen in 5 colors. And through the magic of modern editing, we should be able to get complete inking. And just like that, easy peasy inking. Go ahead and you can try it at home now. Okay, let's take a look at what we did here. So ideally I wanted to demarcate all 5 margins as clear as I could, so you could see nice clear lines between each of them. I went ahead and inked the medial margin yellow, lateral margin orange, inferior green, posterior black, and anterior red. And again, we don't have a superior margin that I needed to ink this time, but I could have inked that blue. Now, additionally, I wanted to try and avoid getting any ink on my bone resection margins. The problem being that the bone marrow is very porous, and if you apply ink there, it can actually seep into the margin, thus creating a false margin on the inside. So your distal and proximal margins of the bone should not be inked. Now, if you get bone on the or ink on the periosteum, that should be fine, but ideally you can just avoid it and keep the ink on the soft tissue. As you can see, there's a little bit of a bleeding there, but keep those as clean as possible. Additionally, notice that my ink goes all the way up to the cut surface of the mucosa. So I'm inking, in essence, the mucosal margin as well as the soft tissue margin, all the same color for that margin. So my mucosal medial margin has yellow ink on it, as well as my mucosal or soft tissue medial margin. Okay, so let's go ahead and take a look at what we might have in the form of pathology and grossing. So like I said, some of these can actually occur in the along the alveolar ridge, which would be right here, so you can see the top of the mandible bone, and this would be the ridge. This would be where my lip mucosa will start, as well as buccal mucosa towards the cheek, and then I have the molar, retromolar mucosa as well. So you can look for tumors there. Sometimes they'll actually be on the alveolar surface, and maybe eroding into the teeth. This specimen does not have any teeth, but if yours does, just do your best to work around them. Or it could go base of tongue, so I could see a tumor on here as well. So what you're going to do when you get a specimen like this is either before or after inking, we're going to want to go ahead and measure the specimen in 3 dimensions. So what I like to do is measure the specimen as a whole, so we can say the specimen is
7.5 by 5.5 by 3.2 centimeters. And then you can go ahead and measure the identifiable components. So I can say that the specimen consists of a partial glossectomy, which measures 5.0 by 2.5 by 2.5 centimeters, and it consists of a portion of mucosa measuring 5.8 by 2.1 centimeters, with a section of mandible measuring 6.5 centimeters in length and 2.5 centimeters in diameter. You typically don't have to measure the soft tissue components, as that's kind of assumed with the rest of the measurements, but any individual or interesting components that stand out, feel free to give those a measurement as well. I can indicate what colors I've inked this specimen, and then I'll go ahead and describe where my tumor was. So, let's say that we have a tumor located right around the base of the tongue. So I'm going to go ahead and put one of those on there now. There we go. Now, the first thing I want to do is measure my tumor, and typically it might just be an ulcerated lesion, so I'll give 2 dimensions, which will be 1.2 by 0.9 centimeters. And then I'm going to go ahead and measure it to the superficial margins. So on my mucosal surface, how many margins do I have? That's right, 4. We went a little Dora the Explorer on this one. So let's measure it to the anterior. So it's 2.4 centimeters to the anterior mucosal margin, 2.5 centimeters to the posterior mucosal margin. Now notice this, we've got a nice little fold here. So I want to make sure I factor that fold in as much as I can. So I'll try to tease it out and flatten it and say that my medial or lateral margin is 3.0 centimeters. And then I can go ahead and measure it to the medial mucosal margin, which is going to be 5.0 centimeters. Okay. Now this one does have the likelihood that it looks like it could be involving bone. So we want to go ahead and test that. But as far as sections go, the most important thing to do at this point, and chances are frozen sections would have been sent down with this specimen, and if not, you might have to do it actually on the specimen. But now we want to do a margin assessment. So your most important sections are getting tumor to every possible margin if you can, otherwise getting a representation of that margin. So if my tumor is located kind of in the central, it's feasibly possible that I can get it to all 5, at least maybe 4, if not 5, the deep margin of the margins, as well as the underlying bone. And again, if you remember earlier, I said we can double up on those margin and get it into the, include the mucosal and soft tissue in one margin. So that means most of the sections we're going to take for these specimens are perpendicular sections. Okay. So, unlike other specimens where normally we approach them by serially sectioning them and then taking our sections, for this specimen I recommend taking our sections and then serially sectioning after that. So what we want to do is, if we can get tumor to a perpendicular section, and remember our cutoff is probably about 2 centimeters, if it's within reason to do that, and actually doesn't look like many of our margins are, so maybe I should have a bigger tumor. But if it's within reason to do that, then I'm going to go ahead and just section towards the actual tumor. Now, one of the things you might notice as you serially section is the depth of invasion on the tumor. Now, this is also an important staging criteria. We want to make sure we make note of the depth of invasion. If it's within the soft tissue component, that's an easy to measure, and you want to go straight down from the mucosal surface. So remember, tumors invade down. So if this was on buccal mucosa, the depth would actually be from the mucosa towards the nearest deep margin. In this case, it's going down. The deep margin will actually be towards the bone in the underlying inferior margin. So keep that in mind, and what I'll try to do is serially section as best as I could afterwards, since I'm not going to be able to get any good perpendicular sections. Let's serially section the specimen and then see if we could measure the depth of invasion. So what we'll do is, if we can't get an easy perpendicular section, now we can go ahead and start serially sectioning to see what else we might find out about the tumor. Additionally, during this time, you can go ahead and take representation of all of your mucosa and soft tissue margins. So if realistically we're not going to be able to get tumor to our mucosa margin on the medial side, let's take a shave of that and just submit that in a cassette. And ideally we can submit that on FOSS, so they'll be cutting into the margin. Now, notice here with our medial, the mucosa is much higher and much farther away than the actual tumor. That has a lot to do with the tongue being attached. But our medial soft tissue is actually a lot closer to the tumor if there was invasion below. So what we will do is we'll serially section on the medial aspect and see how close the tumor would be invading to the soft tissue. And in that case, we might have to submit a different tumor section to soft tissue margin, even though we were able to claim to shave off the mucosal margin because it was far enough away. So let's continue shaving. Now, in these specimens, go ahead and use the mandible as your sort of bookend and just cut up to it. It'll start dulling the blade, but it'll kind of give you the mucosa, or sorry, the soft tissue should hold on to the bone pretty readily. Okay, after we serially section this guy, now we're going to actually want to measure the tumor in its entirety. So one interesting thing about these specimens is that sometimes you have a little ulceration that doesn't look like much on the mucosal surface, but when you start digging into the soft tissue, on the underlying tissue of the mandible resection, the tumor is often a lot bigger. So you can kind of think about this like an iceberg. So you get a nice little small tip, but once you go on the inside or underneath the surface, what you'll see is a larger tumor. So oftentimes it might be necessary to measure a tumor measurement in 3 dimensions that's a little bit different than your ulceration measurement, and that's perfectly fine. Just make sure you correlate it to the ulceration. So I would say upon serially sectioning, a mass is identified that measures 3.2 by 2.5 by 2.5 centimeters that corresponds to the previously mentioned ulceration on the gingival surface. And that way it gives my tumor an actual measurement. And then this time you can also measure your depth of invasion. You can say the tumor measures has a depth of invasion of 1.5 centimeters and approaches, and at this point we want to measure to the nearest margins. So not only do we have to measure margins on the mucosal surface, those might be different because of that iceberging, and I don't know if that's a technical term, but I think we'll go with it. We have to measure the distance to your soft tissue margins at this point, which may be different, and they actually may be closer. And at that point, you might need to get your sections from the soft tissue margin to tumor as a perpendicular section. So after sectioning it, we'll give our measurements for the tumor, and then we'll go ahead and measure to the 5 soft tissue margins. So before we could measure to those mucosal margins, and that's 4 measurements, now we'll measure to the 5 soft tissue measurements, including the deep margin that we didn't have to include before. So at the end of the day, you should have a representation of approximately 9 margins, but realistically a lot of those can be buddied up. Like I said, anterior soft tissue and mucosa, and posterior soft tissue and mucosa will probably be about the same, especially since there's minimal amounts of soft tissue attached to the anterior side. So once you've given all those measurements, at the end of the day, what you need to submit are just tumor representations to those margins. So you need to have tumor to all 5 soft tissue margins somehow represented, or just those margins as shaves, and to the mucosal margins. Those can be doubled up in cassettes, so you can have mucosa and soft tissue margin in a similar cassette. You just have to make sure in your cassette summary that you actually say this is a representation of the anterior mucosa and soft tissue margin, or this is tumor to lateral soft tissue and mucosa margin. And once you've recognized the closest of those margins and submitted those, then the only sections to take are going to be your sections of tumor. And now we also want to try to get the most important section we can of our tumor, which is tumor to the underlying bone. Sometimes you can do that with a scalpel. If the tumor is invading the bone, we can just cut through it, and it's usually pretty soft, but sometimes we'll have to actually get a striker saw or a hand saw to do that. In which case we'll just cut through it and try to keep a little bit of soft tissue attached. Now, any bone sections are likely going to need decalcification, so the most important thing to remember is you want to make sure you're submitting tumor sections that are not going to undergo decalcification. While the invasion section is the most important, we also want to make sure we can diagnose the tumor, and if they need to run special studies on the tumor cells, decal will not allow that to happen. So get your tumor to bone, even if it's not invading, but also get additional sections of tumor. Now those can also be included in your tumor to margins as part of your 1 per cm, but make sure you kind of get those representations as well. And then finally, after all my soft tissue is cut, then I'm going to go ahead and section the distal and the proximal bone margins and do shaves of those and submit them in a cassette as well. They should be in individual cassettes, and they should be decaled as well. So those you almost always have to decal regardless, because they should not be positive for tumor. Some places might be okay with just submitting bone marrow sections, so you kind of scoop out the bone marrow, and that'll require significantly less decaling, and it won't require you to actually use a striker saw. And if that's the case, we don't really have an opportunity to do this in the cadaver, but you would just go in with a some forceps or some tool and just scrape out some bone marrow and submit that as your anterior and posterior margin. So ideally, and let's go ahead and finish our cut on the medial side, and I'll show you how to maintain a good section. So let's say we have our tumor here. So I've cut it. I usually like to leave a little bit attached so I can come in with a striker saw and then take that representative tumor to the underlying bone as one whole section. So see how it's still attached to my mandible? Well, now I can just go in there with a striker saw on either side and just cut that out. But all the soft tissue cutting I recommend doing first, because you want to get those sections for the margins, and then at the end of the day the bone will be relatively undisrupted, so you can go in and take your striker saw sections after you've taken your soft tissue sections. So let me go ahead and take my sections here, and then we can kind of review those as well. Now we're going to take our bone margins and our bone sections by using a striker saw to get the anterior and posterior. Once you've taken the anterior and posterior bone margins, note that they sometimes do break because the marrow cavity is quite large in these specimens. We're going to actually go for the lesion next. Once the specimen has been bisected, you can go ahead and do the same thing you did for the anterior posterior margin to take the remaining section. And there you have it. Although these specimens do look complicated, you can see that applying the principles of margins and basic anatomy means the sectioning is actually pretty straightforward and simple. Should you get a specimen like a maxilla, it's pretty much the same thing. Just be mindful of your margins and take those soft tissue and mucosal margins as necessary. So thank you for joining me today, and I will see you in class.